All right. Good morning. I hope everyone can hear me all right. I am Dr. Glenda Tiller, and I have the pleasure of introducing our speaker today as the chair of the Clear DEI subcommittee. Thank you. Uh, our speaker today is Alyson Myers, MD. Our program is underwritten by an educational grant through OSU Medical Center Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. Alyson Myers is an associate professor and the associate chair for diversity, equity, and inclusion for the Department of Medicine at Montefiore Albert Einstein in the Bronx. She also is an adjunct associate professor at the Zucker School of Medicine at Hofstra Northwell, where she also served as the medical director of inpatient diabetes for North Shore University Hospital from 2013 to 2021. Dr. Myers attended the University of Virginia, where she majored in French and minored in chemistry. After college, she returned home to Queens, New York to teach junior high school math and science. A year later, she attended SUNY downstate for medical school, where she was the four-year recipient of the President's Award Scholarship. She completed a 5-year combined internal medicine psychiatry residency at Rush University Medical Center in Chicago, Illinois. During her fourth year, she was selected as chief resident. After residency, she completed an endocrinology fellowship at the University of Texas Southwestern. During fellowship, she received a T32 training grant in mood disorders and diabetes under the mentorship of Dr. Madhukar Trivedi. In 2022, she was co-awarded a Center for Diabetes Translational Research grant to further examine and improve the health outcomes of persons with diabetic foot ulcers. Her goal is to lower the high rate of amputations of Black and Brown persons with diabetes in the Bronx by using multidisciplinary care and limb salvage techniques. Dr. Myers has several publications on the topics of diabetes disparities and diabetes technology. She has been a longtime reviewer for several journals, including Journal of Immigrant and Minority Health, Journal of Diabetes Science and Technology, and Diabetes Care. She is also editor of an upcoming book with Springer Publishers on the topic of diabetes and COVID-19. Also, she is an active member of the Endocrine Society as an abstract reviewer. Member of the Publications Committee and a lead for the Excel program, which provides leadership training for endocrine fellows and early career attendings. Dr. Myers also serves on the American Board of Endocrinology, Diabetes, and Metabolism. Please welcome Dr. Alyson Myers.
Thank you. I appreciate that wonderful introduction. Can you all hear me fine this morning, Dr. Tiller? Okay, perfect. Thank you. So today's talk is entitled There is More Than I in Inclusion, Making Workspaces in Academic Medicine. Inclusive is pretty much what we're doing. And, unfortunately, there has been a campaign against DEI where they're now calling it DIE. So I think this is a really apropos conversation to have at this time. I will forewarn you that there is interaction. So I'm going to ask there's some points for people to put comments in the chat. So this way, this is interactive because I also want to get feedback from you all about what your experiences have been. So as mentioned earlier, I have nothing to disclose. And the objectives of today's talk are threefold: to differentiate between diversity and inclusion, to illustrate the historical events which have made medicine non-inclusive, and last but not least, to describe how to create an inclusive environment for trainees and faculty. So my first question, and again, you can send it to me anonymously in the chat or group, is can you give me your definition of diversity and your definition of inclusion? So I'll just give about 20 seconds. And if you want to send it to me anonymously, that's fine. If you want to put it in the group, you have the ability to do either. So what comes to mind when you think of these terms? Okay, we have diversity is having a variety of people. Okay. Any other thoughts? Inclusion is ensuring that all people, of those people fit in. Okay. Diversity means having individuals of many backgrounds, and inclusivity is to include them all. Okay. Diversity, bringing together people from different backgrounds and lived experiences, inclusive of race, ability, gender, identity. Okay. A sense of belonging. Okay, great. Thank you. So as we go through this, we'll see that these are going to be the common themes that we will be talking about today. So here's an example I think that's great from medicine that really highlights what diversity can do and why inclusion is so important. So I call this the tale of two Americas, the healthcare system. This was a cartoon that was in the New England Journal not too long ago, submitted by a physician who was talking about her first day of medical school. She said, I can distinctly remember how hopeful I felt on the first day of school as an aspiring surgeon. I was especially eager to prepare for my anatomy class. But then what happens? My heart sank as I looked across to see another group unpack a full surgical tray donated by a student's father, a surgeon. I immediately started to doubt my ability to succeed. How can I compete when I was behind from the start? This generational privilege is the oldest form of affirmative action, and it continues to challenge any efforts to create a level playing field for physicians from minorities that are underrepresented in medicine. In academic medicine, we also have limited exposure to professors and mentors that look like us. My secret weapon for surviving medical school was the mentorship of an accomplished senior professor, Dr. James Bowman. He was a pioneer in sickle cell anemia research. She says, I feel so out of place sometimes, Dr. Bowman. So Dr. Bowman then tells a story. In 1947, which actually was not that long ago, this is when Dr. Bowman first started his residency. All workers of color had to enter the hospital through the back door, and that included even physicians. From day one, he refused to enter through the back, and he went through the front just like every other physician. And word got around, and then by the second week, every worker of color from environmental services to nursing wanted to walk through that front door with him then and every day thereafter. He reassured and encouraged me to be my best self. My determination would make up for the disparity. Don't worry about others. Your best effort will be enough. And those words of encouragement helped guide her through medical school. So my question is, how many can relate to this story of Dr. Bowman or this other physician in which you felt like when you got to medical school that you didn't belong because people looked differently than you or people had more opportunities than you? And again, you can put it in the chat to me anonymously or to the group. And remember, when we're talking about minoritized, it may not just be a matter of race or ethnicity. It could also be gender. It could be socioeconomic status. It could be first generation, college, sexual gender or identity. I know personally for me, I could relate to it because one of the first days when I showed up as an attending, the parking lot attendant said, "This is the physician's parking lot," and I had to reassure him that I was a physician and that's why I was parking there. And that happened to me actually in another parking lot. So things like that in the morning is not something that you necessarily want to deal with. So I can definitely understand. Anyone else have any similar? And again, you can send it to me directly if you don't feel comfortable sending it to the group about how it feels to not feel included when you enter the space of academic medicine. Right. So someone mentioned that as someone who is in a minoritized community, based on their sexual identity, that they felt similar because they didn't have mentors who had this lived experience. Absolutely. And this is why diversity and inclusion are important so that we can have a workforce that mimics the patients that we're taking care of and our providers feel supported. So when we think of diversity versus inclusion, I had asked you earlier for definitions. And when we think about diversity, it's the what, whereas inclusion is the how. So when you're diverse, you can have a seat at the table, but when we're inclusive, we can have a voice at the table. So that means that all the voices are not homogeneous, they reflect different backgrounds as well. So the other question is who is in the room versus has everyone shared their ideas? So you can have a diverse group of people sitting in the room, but is that same diverse group of people able to speak up and share their ideas and be respected? Diversity is also a state of being diverse or having a large variety. But when we're inclusive, you're not only having this variety, but you're also respecting and supporting the variety. When we think about diversity, we think about things that were mentioned in the chat earlier, demographics like gender, race, age, sexual orientation, gender identity. But when we're thinking about inclusion, we're talking about how all these different identities, whether they're intersectional identities or not, how they can coexist and be beneficial to us as a workforce, as well as our patients. And of course, diversity brings different people into the same territory, whereas inclusion, we're introducing concrete methods and strategies to make diversity work. So it's good to have a diverse population, but are we allowing this diversity to work better for us? Are we allowing this diversity to have an equal seat and footing at the table? So that's the key difference between diversity and inclusion. So how did we get here? In order to figure out how we got to this place where we need to talk about diversity, equity, inclusion, we need to look back to the historical origins of our country. So when people look at this diagram, what does this diagram represent? Any thoughts? And again, you can direct message me if you don't want to put it publicly in the chat. This is here in my home of New York, where you see on the left, settlers from Holland. And to the right, we see the indigenous. So the indigenous people that were here, the land that I'm on is of the Lenape people, many of whom have been displaced either to the Midwest nor north as far as Canada. And I know that you take care of a predominantly indigenous population. So when you see images like this, what does it represent to you? All right, so an invasion of indigenous lands, exactly. Any other thoughts? So there's also a power dynamic, as you can see here. So the Europeans are fully dressed and clothed with guns, whereas if we look at the indigenous folks, we see the women are bare-breasted, kind of in the background in a more subservient type of role, and even the men are scantily clad, and their weapons are made to look like they're not as advanced as those of the European. And also, as someone mentioned, you can see the settlers look like they're just coming to save the indigenous. No real respect for the fact that the indigenous folks have been living on this land, tending to this land just fine for hundreds and hundreds of years, but it's looking like somebody has to come and save them. It's kind of just like really primitive appearance that they make here as opposed to these men. So you can see there's a definite power dynamic in how we capture the true history of the origins of the original people here in America. And then we know, unfortunately, many of our Native American ancestors were unfortunately murdered or developed diseases. And then after that, we had the introduction of the African slave trade, in which Africans were brought, millions of Africans were brought, but most of which went to the Caribbean and South America more so than North America. And that started a transatlantic slave trade. And then as we went through time, we know that in the late 1800s, that the African transatlantic slave trade was made illegal and it was outlawed. And so after that, we had the period of Reconstruction. During the early 1900s, as Reconstruction was starting to end, we had what was called the Flexner Report. So we know that Abraham Flexner was charged with the task of accrediting medical schools. The problem with Mr. Flexner was the fact that first and foremost, he was not a physician, but he was given this task. Secondly, His idea of good medical care was mimicking that of the German medical schools. He found that Johns Hopkins was the top tier medical school, and that was the school that other schools needed to emulate, which meant that some of the schools that they had that specifically were training women or people of color did not meet his standard. So in the early 1900s, there were 7 schools that were designated for people at the time who were identified as colored. And because Dr. Flexner did not think that they were up to speed, he actually closed 5 of those schools. He also felt the need to close the schools that were made for women because he felt that women should go to school with men. But we know that during that time, sexism was real. So a lot of schools were not admitting women into medical schools. And that's why we had a long period of time where you saw there was this stark difference between the number of women that were entering medical school, and we have the continued difference between people of color matriculating as well as graduating from medical school. Back in the early 1900s, roughly 6% of physicians were Black. That still holds true today. And there was actually a study that showed that if these medical schools were not closed, there'd probably be 20,000 more Black physicians today. But due to the fact that Mr. Flexner was able to close these schools, we decreased a pipeline to continue to have diverse physicians in medicine. And then, of course, that makes it non-inclusive because he did shut down these schools that were hoping to promote having more physicians that come from different backgrounds. This was further worsened by the fact that the American Medical Association was not even supportive of women and people of color. So back in 1968, they had a national meeting and they were actually hoping to discuss whether or not they would admit women. But of course, they did not. And so they said that since female physicians were qualified practitioners according to rules of reason, unbiased by prejudice, that the AMA has no right to refuse them admission simply on the ground of sex. However, they said that this issue should not be taken up on the national level. It was left to the local societies. So although they said we should not discriminate, they said they would leave it up to local societies whether to admit women or people of color. So if you had a local society in Oklahoma or New York and people didn't feel the need to let women or people of color in, they had the right to do that. It wasn't until later in the actual 1960s that they actually enforced their rules, and they made it across the board that they had to admit people of color into the American Medical Association. So again, when people don't have opportunities because local organizations and medical schools are not inclusive, that's why you're not going to have a diverse workforce. And we know that when we talk about these things, it's based on privilege. And we know that if you belong to certain groups, you're more likely to have privileges than if you don't. So in our society, we know that if you're considered male with masculine features or female with feminine features, then you have the privilege of gender. We know that if you're in terms of race, if you're white or European in origin, as we saw from the previous painting, that there are also advantages of privileges, as well as being heterosexual, being able-bodied, people who are neurotypical, people who are credentialed, highly literate, who come from high socioeconomic status, more attractive. These are going to be the people that are going to have privileges, and these privileges extend to medicine as well as other fields. Whereas if you are on the other spectrum, where you're not from the dominant religion, which is typically in this country Christianity, if you're darker skinned, English is your second language, you're working class, you're older, you can't read very well, you're able or you have not abled or you have disabilities, you're a sexual or gender minority, you're going to be less likely to have some of the same privileges. And one such privilege is if we look at who actually enters medical school. So this was a study looking at people who were matriculating into medical school, and they would look to see what was the socioeconomic status of people who are going to med school. So if we look overall in the United States, we can see that most of the population, which would be we would say these blue bars, this majority of our households, 80%, are going to be not in the top 5%. Okay, so mostly maybe about 10% of all US households fall into the top 5% of economic quartiles. So this is the wealthy of the wealthy. Whereas if we look at medical students, So here we see maybe about 5 to 10% in the whole entire US. When we look at people who go to medical school, we can see there's a disproportionate amount of more people that come from this higher quartile of economic standing here in the United States, which means that having a higher economic status is more likely for you to get into medical school. When they break it down among race, we see some of the same similar trends in terms of people who identify as non-Hispanic Asian, as well as non-Hispanic white. But when we look at people who identify as non-Hispanic Black or Hispanic, we can see there's a smaller amount of this top 5% wealth. Even when you look at those who are ending up in medical school, there's a disproportionate amount of people that don't fall into this top 5%. So these again are why we have the disparities that we're seeing as to who comes into medical school, because those who have higher economic status are more likely to get into medical school. And as mentioned earlier in the cartoon, when you don't have generational wealth from the numerous things such as redlining and other issues, it's going to make it harder for you to get to this top 5%. So what can we do to create a more inclusive environment in academic medicine? Well, when we think about this, we have to think about what can we do as individuals all the way up to the level of our institution. So some things that we can think about are what are things that we can do to be inclusive. So sometimes that means leaning into the discomfort. That means sometimes that you have to challenge yourself as well as others, and speaking up and bringing your voice. For example, one of the things that we had here is we found out that people felt that people could not report things because they were afraid that things would happen, like they would get blackballed or the higher ups would not listen. So one of the things that we had to put into place was making a conflict resolution team. So this way, if somebody felt that they couldn't go to their supervisor, which is the usual chain of command, they had an alternate way to be able to speak up. So that's one example of things you can do. But also it's about listening and being an ally. Sometimes the people that are doing the work, what we call the minority tax, get tired. I remember one of the speakers I had, he said, he said to me, as a gay man, sometimes I get tired about speaking up on gay things. Sometimes I need someone else to speak up on it. And I can relate to him because I feel the same way sometimes as a Black woman. Also, it's important that we state our intent and intensity. Sometimes it can be a matter of someone says something and they didn't mean it in a derogatory way. So sometimes it's good to have conversations about, well, what did you mean by that? This is how you made me feel. And then also sometimes we have to feel uncomfortable in accepting how other people may feel differently about things. And that just because someone thinks differently, it doesn't necessarily mean that they're wrong or it's bad. Also, a big part of this work in terms of inclusion is involving everyone, but making sure that we're not abnormally taxing certain people to do this work. We want to get everyone's opinions and feedback, but we don't want to have endless meetings. We don't want to drain people to be the spokesperson for certain minoritized groups. So when we think about allyship, there's more than one form of allyship. And I think we have to reflect on the fact of, am I a performative ally or am I a demonstrative ally? Do I have the tools to call out these microaggressions? And can I use my privilege to help other people? We saw the privilege wheel. We know where we stand on that, on which side we stand on. Are we able to use those types of things that allow us to be privileged to help others? And can I change a culture as an individual, or can I also rally other people to change a culture with me? So when we talk about allyship, as I mentioned earlier, are you performative or are you demonstrative? Are you the type of person who puts a sign in your yard saying, I support these matters? Or are you the person who's out there actually doing the work to try to make sure that change happens? So performative allyship is defined as when someone from a non-marginalized groups professes support and solidarity with a marginalized group in a way that isn't helpful. It's also known as performative wokeness. So again, are you just putting a sign in your yard, or are you actually going out and doing the work to help make real effective change? And the demonstrative allies, those are the people that are active, they're consistent with a lifelong practice of unlearning and relearning in which a person in position of privilege and power seeks to operate in solidarity with the marginalized group. A lot of these people who are allies, you may never see them. It could be people who are secretly donating to organizations. These could be people that are going out volunteering in the streets to help people who are undomiciled. Sometimes sometimes the allies that we have doing the work are not exactly visible. And that's usually what allyship is. It's the people that we don't see. It's not the ones, like I said, that are wearing just buttons and signs, but it's the people that are really doing a lot of the behind the scenes work. And if you're not sure how to be an ally, that's when you can actually get training in this. For example, one of the organizations, it was called Right to Be. They used to be known as Holla Back. They actually do bystander training where you can learn what to do if you see something that is discriminatory in nature that's happening. There's also books you can read to learn more about this if you feel uncomfortable about how to go about transforming yourself from a performative to a demonstrative ally. And so, as I mentioned, there are some books, and these are a couple of books that you can read. These are about race. There are other books, obviously, dealing with other marginalized issues, but How to Be an Anti-Racist, White Fragility, Black Fatigue. And so you want to talk about race or some examples of things that you can read to deal with racism. But it's really important that if you're an ally, that you can vocally support, not just do it behind closed doors. And also it's important to validate people's experiences. So we talked earlier about what happened with Dr. Bowman. Someone else also referenced, I also referenced, it's important to actually make people feel like they're supported when they tell these stories, as opposed to saying, oh, that's no big deal. I don't understand why you're talking about that. And if you really don't feel like you're aware about it, it's important to read these types of books to learn more and also to reflect on how your own privilege can also be used to help improve people's from marginalized background situation. And acknowledging when you see something, saying that's homophobic, that's Islamophobic, that's racist, that's sexist. These are things that should not be tolerated, and silence makes you just as complicit when you don't say anything. So the definition of allyship is an intentional practice in which persons in positions of privilege and power build authentic relationships with marginalized groups based on trust, consistency, and accountability in order to address unjust power structures in a manner that the community can recognize, acknowledge, and name. So I'm going to give you all an example of how you would practice your allyship. And again, you can send it to me as a direct message, or if you want to send it to the group, you have the option. So you have this experience where after rounds, the nurse pages you as Mr. X would like to speak with you. Mr. X states that he does not want the intern to be his doctor anymore because he does not like their kind. So you are the senior resident. What would you do? A, reassure Mr. X that his request will be fulfilled. B, ignore Mr. X as he's probably under the influence of his pain medications. C, tell Mr. X that he's racist. Or D, ask Mr. X what he means by his statement. So again, if you want to not, you can either put it in the chat and to everyone, or you can just directly send it to me if you have the option of either. All right. So far I'm seeing one letter. Okay. So it looks like the overwhelming answer is D, and that would be correct. So it's never we never can tell a patient that they will not be taking care of someone because they don't like their kind. Obviously, if there was some issue from the resident who says that they don't feel comfortable taking care of this patient because the patient spoke to them in a certain way, that's different. But we can't just pick and parcel like this for patients. So A is definitely wrong. B would also be incorrect because then you're just kind of sweeping it under the rug and not addressing something that could be a serious issue. C, we never want to name call without really knowing what's going on. So that's why D would be the best thing. But what Mr. X means by his statement. So good. And so these would be obviously described, this example will be described as a racial microaggression, which are usually subtle, stunning, often automatic and nonverbal exchanges, which are put downs. And these terms were originally came about from physicians who practicing in the world of psychology. This is Dr. Sue, and they found that these words can actually be very painful over time for a lot of people, and that they can be harmful, and they can also impact your ability to function at work. And so if they go unnoticed, it can have detrimental effects. So when we think about microaggressions, there's actually several types. There's the micro assault. Oh, sorry. Okay. This is when you have derogation characterized primarily by a verbal or nonverbal attack meant to hurt the intended victim through name calling, avoidant behavior, or purposeful discriminatory acts. So we just had the example when someone says you people or you're kind, for example, that would be a micro assault. Then you have the micro insult. And this actually was a tweet by a professor from Columbia University who was actually the chairman of their psychiatry department. And he said, whether a work of art or freak of nature, she's a beautiful sight to behold. So obviously, this is a very degrading comment to make about this model here. And it's a micro insult because it's characterized by communications that convey rudeness and insensitivity and demean a person's racial heritage or identity. Her skin color does not make her a work of art or a freak of nature. An example that I once had was that one of my colleagues who's Korean, she was quite upset because one of the white partners in our group used the term Oriental as opposed to Asian. And she noted that I am not from the Orient, neither are most Asian people. So I find this really offensive that in 2000, someone would still use the term Oriental to describe me. Another good example of a micro insult is using the term black cloud, which denotes that black is bad, whereas the white cloud is something that's good. So that was something that we often heard in residency. The bad luck resident who got all the bad admissions was the black cloud, and the one who didn't get all of that was the white cloud. And then, of course, this one, for example, is another. Then we have micro invalidations, and this is characterized by communications that exclude, negate, or nullify the psychological thoughts, feelings, or experiential realities of persons of colors. And then one of the examples that I can think of is this example of all lives matter. And yes, all lives absolutely do matter. But when there is a disproportionate number of people who are being murdered, we need to speak up on it. So it's not to say that all lives don't matter, but to acknowledge, not to acknowledge the fact, and this was actually done with the Washington Post, that there are more Black or Hispanic persons killed in police custody than white or others would be invalidating to people and very untrue. And they really can be real, these microaggressions in the workplace. This was a cross-sectional analysis that I did with a colleague in my previous job. And when we asked women in the past 6 months, or what were they dealing with in terms of the workforce and microaggression, 1/3 said they felt ignored in the workplace. Another third felt unheard, and almost 40% said people assumed that they cannot contribute to the conversation. So if people feel ignored, unheard, or that they can't contribute, how are we making our workforce inclusive? And this is a good number of people who felt this way. Yes, it's under 50%, but it's still a pretty robust number of women who felt that this was a problem. And some of the examples of microaggressions that women expressed in this study, someone said, I'm a leader in a medical group. On numerous occasions, I've explained something to the group only to have a male colleague restate everything I said exactly and then have everyone respond to him. This is not my comment, but I've definitely experienced that in a meeting as well. One of our surgeons mentioned that she wasn't offered block time due to low case volume when her male partner was and had done equivalent amount of cases over the same period. Also having physician's assistants instruct her to complete the pre-op paperwork on arrival to the hospital while they would arrive early for other surgeons. So the male surgeons are getting one set of treatment and she's getting another. She also was asked to modify her clinic schedule to make the other male physician requests for having their clinic schedule more frequently disrupted with x-ray maintenance and office construction, so she'd be less likely to complain. So this poor woman was definitely getting dumped on. And then the last one, which I think a lot of us have definitely experienced, when a nurse calls you by first name in front of the patient, but your male colleagues get addressed as doctor. When you walk into a patient room and introduce yourself as doctor, but they're on the phone and say, hold on, the nurse just walked in the room. When you walk into a patient room with a male medical student and the patient assumes that that is the doctor. When your patient demands to see the doctor and you have to repeatedly say, I am your doctor. When you're sitting in the ED writing a consult note and someone walks up to you and assumes that you're the nurse. So again, definitely common themes that we saw. And overall in the sample, 85% of the women said they dealt with microaggressions. And I think that unfortunately, for many of us, we can relate to all of the above. So how can we be microaggression allies? So there's a couple of techniques that we can use. This is one example from the University of Toronto, and it's the CARES mnemonic. So C stands for consider. Consider how what you said was harmful. So in the previous example, it's not that nurses are bad people. We love nurses, but it's just that when you're wearing your MD tag and you identify yourself as Dr. So-and-so, it's not fair to then be called the nurse. Then it's being accountable for your actions and being willing to apologize. It's rethinking some of the stereotypes. So there's the assumption that the woman is the nurse and the man is the doctor. And then empathize with those who are in the receiving end of the microaggressions. And lastly, support by offering resources how you can help with that person's how they're feeling at the time. A couple of other things that you can do. There's a mnemonic called open the front door. So what that really means is you open the front door by observing the interaction and then afterwards saying, what do you mean? What did you feel? And what did you desire by making that comment? Another one is action, which means asking for clarifying questions and trying to come from a place of curiosity, as we did with the example earlier, not so much to attack the person so that they will get defensive. And owning your thoughts and letting that person know how you felt. There's also XYZ, where you're using this X to say, I felt X when Y because of Z. So I felt hurt when you called me nurse because I introduced myself as Dr. So-and-so. Another one is PEARLS, which stands for partnership, empathy, apology, respect, legitimization, and support, which is similar to the CARES mnemonic. So partnership is to come up with a joint problem solving. Empathy is pretty straightforward. And apology is like here being accountable. And respect is the respect for a person's choices, behaviors, and special qualities. And then you want to legitimize so the person can feel like you're validating their experience and then you support them. And then last but not least, we've had social media campaigns. So I'm sure most of you were familiar with some women who had posted pictures in bikinis, and because they were surgery residents, someone felt that it was inappropriate, and there was this whole brouhaha. So several female surgeons started a social media campaign in which they had hashtag I look like a surgeon. So why is it if a woman is in a bikini, she doesn't look like a doctor and that's inappropriate, but if a man does the same thing, it's okay. So a lot of these double standards that are happening, unfortunately, for minoritized individuals, don't make medicine an inclusive place. And that's why using these techniques can help ease the burden for people who come from minoritized groups. So the other thing that's really important is having sponsorship or mentorship. So as we saw in that earlier cartoon and as mentioned earlier by somebody, if you don't have mentors or sponsors that look like you, can you find other people that can actually help you move along in your career? So often we say, well, what's the difference between sponsors and what's a mentor? So a sponsor is someone who's going to act on your behavior. What they're going to do is they're going to give you opportunities. This is really important, especially for those of you who are early career, because the sponsors tend to be someone who's like a full professor, someone who's more senior, who is at the point of their career where they don't need the same opportunities that you may need. So I know very often people will ask me, can you give a talk? Can you write an article? And I'm at the point in my career where I do need them, but not really like I used to. So I very often will give it to other folks. I may not be their mentor, but I do sponsor by giving them these opportunities. And then mentors are giving more advice. So those are like, when you have a bad day, what happened earlier with Dr. Bowman, how he kind of, took this young doctor under his wing and told her how she can get through her rough circumstance. That's more of mentorship. But the problem is that when we look at who's getting sponsored and who's getting mentored, there's a clear difference. So as noted in this study, women are over mentored and under sponsored relative to their male peers. What that means is if you're a woman, you're less likely to climb that ladder compared to your male counterpart. This again goes back to this privilege that we have. And men are 45% more likely to have a sponsor than women across industry sectors. So again, if we're going to burst the bubble of privilege and make medicine more inclusive, we need to make sure that women are being sponsored as well as mentored. And that's why mentorship programs are great, but we also need to have sponsorship programs and making sure that our minoritized individuals are getting these programs just the same way as our privileged folks. So just again, to reinforce the examples between mentorship and sponsorship, mentorship can help you drive your career development, focus on some of your personal and professional development, but that sponsor is the one who's really going to get your career moving and going to get you into these career advancing opportunities. And obviously, if you can get the overlap, that's great, but very often people will either serve one or the other, but you may be lucky that you get somebody who can give you both. And when we look at sponsorship, it all also is relates back to what I mentioned earlier about giving people opportunities for publications. We know that you've published in journals like JAMA, New England Journal. That definitely is going to bode well for you when it comes up time for you to go up for promotion. But as we can see, who's getting published? Majority of the public people who are being published in JAMA are white, the same with New England Journal of Medicine. You see very little diversity in terms of other ethnic groups being published in these journals. But let's also look at who is running these journals. So if we look at who the editorial staff is, again, there's at the top, there's very little diversity. You can see predominantly white with a little bit of East Asian. But as we continue to go down, we can see more diversity. So instead of having a top bottom approach, it's the typical bottom top approach that we see in academic medicine just the same. So until we make these things more diverse, you're going to see less diversity in the ability for people who are from minoritized groups to get publications in these journals, which is going to impact the promotion process. So in terms of what I've wanted to do or what I've done here in our institution is I've taken a stepwise approach to figure out how we can move this along. So I think this was one of the best toolkits that I've seen in terms of how we can actually change our own institution to move things along. It all starts with a needs assessment. And I actually hired an outside consultant because I wanted to get as much information as I could from someone who would be unbiased and someone that people felt that they can trust because they are not going to be someone that they have to show up to work with every day. And that really helped me get a lot of good feedback about what things we can do to make this a more inclusive department of medicine. But also, as we go through this needs assessment, looking for the key things that were good, that work well, not just looking for the things that are bad. But then using the good and the bad to try to come up with strategic initiatives. So one of the issues that people had is the fact that they felt that there wasn't enough communication. So we started a newsletter that comes out 3 times a year, focused on DEI, to let people know all the things that we're doing in the department. And in that newsletter, I identify our small wins. And some of the small wins are increased community engagement, because a lot of us, even though we work here in the Bronx, which is a very underserved community, many of us do not live here. So getting engaged with the community is a really important thing for us. And then being able to get to the point where we can craft metrics, measures, and milestones. One of the things that we've worked on is trying to improve the diversity, not only in our residency program, but also in our fellowship program. Although the accrediting bodies don't give us metrics to use, we've built our own internal metrics because we want our body of trainees to be reflective of the patients that we're taking care of. And of course, communication is important. So even though I'm meeting with the chairman regularly, I also like to disseminate. I do what's called days where I go into the office. I call it my DEI tour, and I go and I make myself available and because we're all over the Bronx. So the people, if they don't feel comfortable emailing me, they can come talk to me in person about issues that they're dealing with around DEI. And also, we make this a sense. We make people understand that this is something we see as a or sense as an urgent type of matter. So we don't just sit on our hands. Within 2 years, we've really moved the needle on trying to make DEI a priority here in our Department of Medicine. And in terms of support, my support goes beyond the Department of Medicine. I have other departments that are seeing because we're the largest department what we're doing, and I'm working with them as well. And I think that also makes a difference. When you want to take this whole DEI thing to be important, you want it to be important across your entire institution, not just in parts your department. And so it's really important that we are committed to this. And like I said, unfortunately, they're calling this die at this point because a lot of people are trying to get rid of it. And that's why this tweet says name a scan. Someone says diversity and inclusion because some people are not as committed to it, unfortunately, as others. And so, as I mentioned earlier, we did do actual interviews with people in our department with an outside consultant. And one of the things that we looked at in terms of inclusion is, are we cultivating an environment where every employee feels valued, comfortable, and safe? And what can we do to support people more? Do you feel like your team recognizes your contributions? Do you feel like your manager recognizes your contributions? Those are some of the questions that were asked. And some people said they felt lonely. They felt stretched too thin. It's not enough to get representation. More efforts need to make people feel included and belong. And then some people said that they felt like their contributions were recognized, but we need more infrastructure around inclusion. So these are the things that we were given as task items, providing more education around what inclusion, allyship, and advocacy look and feel like. So and we now have twice-year trainings with all of our executive leadership, program directors, division heads, as well to cover some of the topics around inclusion and allyship. And then also we're doing our job, we're trying to do more around supporting and understanding dealing with microaggressions. So what I just covered with you, trying to teach these tools and techniques to our folks, and as well as more efforts for mentorship, sponsorship, and coaching. I actually created an underrepresented in medicine faculty group in which we do twice year job career counseling, as well as have we have a once yearly session where we get together in person. And so this way people can feel supported as they belong to a minoritized background. And so here, this is from our website, our UM faculty group, and we meet every other month. So in terms of our institutional change and commitment to this whole area of inclusion, it all starts with a mission statement. If your mission statement doesn't align with inclusion, you're not going to create an environment of inclusion. It also comes down to funding. I had a colleague from a well-known institution that I will not name who told me she was given $10,000 a year for DEI, which I think is absolutely ridiculous. And she is serving as a dean. I'm not going to say how much I get, but I can tell you that it's definitely more than $10,000. And these ongoing trainings in our staff to make sure we're addressing things like implicit bias, the microaggressions, anti-racism, cultural humility. And if we stay on this end of denial, in this kind of ethnocentric bubble of privilege, we're never going to get to the point where we need to be, which is on this end, where we're adapting and integrating, and we're putting these experiences of cultures from others into what we're doing. And this is actually something that I think is really good. The Department of the residency directors, internal medicine actually came up with a nice guideline to how to do faculty recruitment and retention for those who are underrepresented in leadership. So this is something that you definitely want to check out. And it starts off with establish a culture of inclusivity. And people are not going to want to go someplace that's not considered inclusive. This is the paper that I did with some of my former colleagues, where we talk about some of the things that you can do in terms of how you can attract, select as well as retain people of color. And some of the things that you can think about are, when you look at your institution, are all the pictures and names in the institution of only white men, or are we seeing different folks that represent our community, that represent our institution? And also, when we're recruiting, are we just seeing the same type of physicians, or are we seeing diverse things? So these are some of the things that we can think about in order to try to recruit more inclusive, more diverse people, to make our, and how we can demonstrate a more inclusive environment. So in conclusion, excuse me, inclusion allows people to feel like they belong, but it also allows people to have a voice. So it's not just enough to say, okay, we're going to have an inclusive environment. It's also about allowing people from different parts of the spectrum to have a voice and to value their opinions. And when we exclude minoritized folks, people who are maybe like on the secretarial level, you actually are going to miss out. Because I can tell you, we have a diversity council, and some of the best feedback I get is not from the higher up doctors on the committee. Sometimes it's from the residents, the trainees, the folks that are not even physicians. So it's important to have all of these people not only have a seat at the table, but to hear their voice. And it's really also important for us to teach and promote allyship, sponsorship, and culture change, so that this way we can make sure that we are really committed to this whole idea of being inclusive. These are my references, and I will turn it back over to you, Dr. Tiller.
Thank you so much, Dr. Myers. That was a wonderful presentation and definitely has sparked a lot of ideas in my mind. Does anybody have any questions for Dr. Myers? All right. Well, thank you so much for being with us today. That was a wonderful presentation, and I look forward to talking to you hopefully in the future.
Sounds good. Thank you.
Thank you.